we've got time at the end to catch up. So we're going to hand over to Liz, who is going to talk about work that you've been doing on Sue as well. I was hoping Sue will be with you to talk about work you've been doing around language in using around mental health, particularly around crisis and suicide crisis. So I'll hand over to you now, Liz.
Yes, lovely, thank you, and thanks for the opportunity to come along and talk. Perhaps, Christy, if we could go to our first slide. Just introduce myself. Both me and Sue, we work for the Norfolk and Suffolk Foundation Trust. We're very fortunate. We're both allowed to work full-time in suicide prevention. Sue does that through her own lived-in experience. I'm sure you recognise Sue, and I've brought Sue in as a bit of a surprise. Just really because she does talk about this a lot better than I do. So Sue, at any point, just chip in where we go. So if we go to our next slide, Christy. I wrote an email to Tom, really sort of begging to come on today to gain your ideas and let you know what we've done and things. But I was asked to attend a professionals meeting for a young 23-year-old female who'd been admitted informally to one of our inpatient wards. Diagnosis of emotionally unstable personality disorder. At the time, she was self-harming and had suicidal ideation, and her care coordinator invited me really because she just says, I can't cope with this lass in the community on my own. Can I have some of your suggestions as to what to do? So a Suicide Prevention League, more than happy to go in onto there. So Christy, if we go to the next slide. As a good nurse, I always look at the notes before the meeting and was pretty shocked to come up with this entry, which is such and such has been struggling with her voices and has spoken about having thoughts to end her life. She stated at the minute she would not want to do this. In hospital, she would upset staff, but reminded it's her choice to end her life, and this is not death by misadventure. If we quickly move on to the next slide, because I think this just brings it home. This is a person we're talking about. This is a young lad, a lass we're speaking about. Well, this is a person we're talking about, and someone's daughter, someone's cousin, friend, etc. And she's also someone who doesn't feel validated, and from being in a place where she needs to be validated, she didn't get those. Didn't get that. And interesting, I was reading the next day she went into the MDT meeting and started to argue the thing that if she did die, it would definitely be suicide and wouldn't be misadventure. And she's got into her head this language we don't want her to have. But it's remembering at all times that good people come into nursing. So what made a good person say something like that? So if we go on to the next slide, please, Christy. The trust is firm. We're very firm. You should never hear this. No, you should never hear that it's okay to take your life. And I've just jotted down a few reasons as to why that is. So if you want to add any more, please feel free. People need to understand that they can never know that someone in suicide crisis doesn't have capacity immediately prior to taking their life. Capacity changes from hour to hour. Capacity is reactive to high levels of distress or mental illness. We have a duty to contact, assess and support. It's never a reason to step back, and why on earth do we ever want to predict or imply a coroner's verdict? If we can move on to the next slide, please, Christy. Unfortunately, it's not new. I do hear it frequently. And if I take us back to a year ago, this is when things started to really change for us in the trust. And it was I can't remember her specific details. She was 20 years old plus, again, with a diagnosis of emotionally unstable personality disorder. And she presented to one of the local mental health liaison teams at the A&E with suicidal ideation, and she got told again she had capacity to take her own life as she had no acute mental illness. This lass communicated her thoughts about the trust and about the treatment she had received through Twitter, and more importantly made everyone perfectly aware of the actions she planned to take as she was driving her car erratically around the streets. Thankfully, 2 off-duty nurses saw the tweets and were able to liaise with her and emergency services, and she was admitted straight away to an inpatient unit. If we can go to the next slide, Christy, please. So what's important is what this triggered for the service. And the next day I had really frank discussions with a service manager who was already on it, and he actually went down to the ward to apologise personally to that young lady, which I felt was good. That was validated. That was really good. And then it brought up this immediate review of the pathways and communications he expected that the crisis resolution home treatment team and the mental health liaison team had. And he was placing far more emphasis on we assess on presentation, not on diagnosis. And this is work that's still carrying on. We're not going to change things overnight. I know we're not going to change things overnight. And this is work which we're still carrying on. So if we go to the next slide, Christy, because it's important to understand what we can, what this triggered for us as a trust. And it was just before World Suicide Prevention Day, and just really before Sue started working with us to the extent she did, because this was brought about a first suicide prevention webinar talking about change the language, save a life, and we actually held it on World Suicide Prevention Day. On the panel was our chief nurse Diane Hull, myself, Sue, using her own lived-in experience, one of our peer participation leads, and a representation for carer, and we spoke about what this means, how this affects different people. It was live to all staff in NSFT, because we really wanted to hear from staff what it was that made them think it was okay to hear, to say this or hear this, or what's going around, what possibly could be happening. We had 500 people watch that live, which out of a trust of 4,000 people isn't bad at all. And a further 325 have downloaded to watch it. And the firm message from that webinar was these words were not to be said in our trust, and we need to understand why they're being said. If we go on to the next one, because our work continues, and what we found, one of the learning from this is that people really liked this way and were able to talk openly on this. So we have webinars now which continue twice a month, and we explore lots and lots of different subjects, and we have experts presenting. So when we say expert, these are people who have been touched by suicide and can really tell us what it feels like, along with people who are working in that field to really inform the whole trust about what's going on. But the theme is always that suicide's not a choice. And also what was commissioned was some bespoke mental capacity training, which Sue delivers with our capacity lead, and that was available to teams who volunteered to say I want it, but also from teams who we know need it as well, and we've placed that on there. Christy, if we can go to the next slide. But we haven't got there yet, and I've seen this come up in the chat because this is a fantastic article which I read the other day from Chloe Beale, who talks about magical thinking and the importance of language, and it's highlighted to me that it goes on in other trusts. I knew it went on in other trusts, but this highlighted to me, and she talks about exclusion in that, and I think Christy's going to put a link to that if people haven't already got it, because I recommend you do read it, about the NHS mental health services structures have become increasingly focused on how to deny people care instead of helping them access it, and well-meant initiatives become you know what I'm like with words, don't you, Sue, on the day, but to justify neglect, problematic language comes up, and we become very risk averse. We lose sight of the human being behind each protected bed and rejected referral. And that brought home to me, if we go on to our next slide, Christy, I'm a mental health nurse. 10 years ago, I worked for the CRHT, and there was so much of this article which I honestly looked through with a highlighter and thought, have I done that? Have I done that? Have I done that? And with a bit of shame, but with, oh my God, how much you've developed, Liz Howlett, is I look back on phrases which I think I've said to people, and I would love to apologise to them for saying it. Such as, people cannot guarantee their own safety. It's your responsibility to make sure I'm not standing up in coroners. I've said that. Someone who presents frequently is at risk of misadventure. We've seen that said. you have capacity. We see it said time and time again. This was a big key for me in my brain. You're the gatekeeper to services. I was the gatekeeper to services. It was up to me where I was going to allow you into one of our very precious acute wards or one of our very stretched community mental health teams. You had to fit a criteria in my head. How many people have we, when we come across drug and alcohol services, have we said to them, right, you need to self-refer yourself to these services to prove motivation, knowing that they're going to fail? We've got to start being honest of it. And this is the one. You're not risky enough for secondary services, but too risky for wellbeing. So you're stuck in between services. And this is stuff which which worryingly, I think we've got to accept. And it's, you know, if we go to the next slide, you know, it's really asking you folks, you know, do you recognise anything like this in your service or even your own practice? If not, you're running a fantastic service and we need to follow it. So tell us what you did. But so, you know, what is actually preventing us from mental health care trusts, from public health teams, etc., all working together to actually change culture so people who need services get them when they want to without a fight. And that's my presentation. Sue, you've taken yourself off microphone, so.
I'm not, I'm here. I am here.
Have you got anything to add, Sue, whilst we've got
No, I think that was just about it. It is something, you know, I had just started, I've been asked to do that bit of work with you when that final thing about that young person who was missing, and I did think I'd jeopardise my job, didn't I? Because I really played up about it and said, I've been told this shouldn't be said, and I was thinking, God, I haven't even signed a contract yet, and I'm playing up about this issue. But it was taken on board, and we did launch those webinars on language, didn't we? And it is so important. But I do have to say, I do still bang on about it, because as a carer myself, I still hear those words and have heard those words, haven't I, Liz? And I just think, why? Where does it come from? Yeah, so.
Yeah, and we've got a future webinar planned. Well, it's next month. Chloe, Dr. Beals, she's coming in to co-host a webinar with us. So we're having a webinar between NSFT and ELF, where we're going to be looking at this exact subject as well. So what else do we need to be doing? It's really what I'm coming asking you folks for.
It's really frustrating to get that message across. I've not just had that said to me by mental health teams, I've had that said to me by A&E departments. And so I think it's across the board that things, it's that first point of contact, you know, as well in A&E departments where you hear those things too, before you even get to the mental health side of things.
Thank you, Sue and Liz. It's really powerful presentation. Quite a lot of comments in the chat of people in agreeing with you, really. I'm going to go to Nikki, who's got her hand up.
Hello, hopefully you can see and hear me. Hiya. Really powerful presentation. Sorry, I can't answer your questions. I work in public health and I coordinate our suicide prevention partnership, and we do have a lot of you know, people from NHS partners who have signed up on their own sort of backs. Are any of your webinars available for people outside of your trust? Because I think they would be really helpful just as a way of to get the messages into local NHS partners, sort of, you know, from the ground up, I suppose.
Yeah, we've one available at the moment. I'll confess, when we started, I wanted it to be NSFT because I wanted staff to actually be free to be able to say, this is how it is, this is what you need to do. And there is a pressure when it goes public of organisational reputation, how much you open up and things like that. So we are now doing more public ones. We've done one on men's mental health, which is available, and we're doing one next week on farmers because it's National Farmers Week, and obviously we're from a very rural community, and so that's something we're doing. I think this is, we've spoke, haven't we? So this is something we do probably need to do a larger webinar, and it's talking to our comms team to do it, and I think I might put it to Chloe to do it, really, because she's really popular. She's an excellent speaker as well.
It's something I wanted from the start. I was really keen once we started doing them for everybody to see the kind of things we're talking about, because I do, suicide prevention is everyone's business, isn't it?
It is.
So yeah.
And it's like what you're saying, is it's not just about one trust, it's about everyone that's involved in supporting people who are in crisis. And it's so we often in Gloucestershire, so where I'm not from, but accent, so where I am, we do have a lot of rural as well, but also we've got a lot of very vocal VCS partners who are people are being told it's your choice, and it isn't a choice. So yeah, if you've got anything, I'll put my email address in the chat, but if you've got anything you're able to share, please, because I know some people will be really interested in it, and I can raise it with my suicide prevention steering group, who are sort of like we're formulating into an ICS sort of thing. So I can share it with them as well, because it's really important. Well done, thank you. Sorry, that's not patronising in any way, shape, or form.
No, it's fine.
I do think that I really do think that it's something we should take back, Liz, because I do think that we've been doing it for a year now, just over a year, and we need to be expanding and having other people share that.
Definitely, yeah, because it's I don't think anyone else has been doing it. So
if you go onto our website, the Norfolk and Suffolk Foundation Trust website, and if you go into events, then you've got a link to our one on farmers next week. And that's where they go. But yeah, I can let you know any.
I think I can put the link in. I'll have a look on my phone and see if I can share it in there, because it will.
Far more technical than me. So
thank you both.
Thank you.
Thank you.
Thanks, Nikki. Thanks, Sue and Liz. I'm glad to see Chloe getting so much mentioned, and she looks like she'll be travelling around the country, or maybe speaking virtually across the country. But I just flagged up as well. I took part in a webinar with Chloe earlier this year, I think, which is available again. She's a brilliant speaker. I'd watch it, not for me at all, but for Chloe and others on there. I'd really recommend it. So, Keith's got his hand up, so I'll go to Keith. Thanks.
Yeah, I'm not disagreeing with anything that you're saying. I'm just trying to put it into a historical context and what this might be a lot about. It wasn't long after I'd started in my career that a few years before that it was illegal to try to take your life. So we had the whole idea that this was something that clearly wasn't anybody's choice. And it was very powerful when it started to enable people to talk about their suicidal thoughts and come forward for help, not being assumed that they were mentally ill or what have you. We used to use common law an awful lot before the Mental Capacity Act in itself came in as a way of trying to balance that. But the Mental Capacity Act made it really difficult when I was working with A&E about what levels you could or couldn't intervene and how you would go. And I think, the thing about the consensus statement and what that is all about is that we've had a shift, haven't we? And in fact, that idea about people having their own responsibility, being accountable for what they're doing and what have you, has kind of made the whole of these discussions quite tricky. And bear in mind, staff are trained almost, or have been indoctrinated into the idea of not imposing things on people, that it is about choice and various other bits. Now, I don't think the word choice is the right one within all of this. However, we've got to be careful, I think, that we don't move too far down the line of making people believe that suicide is something that is in fact going back to being illegal. You can't talk about it, what have you, because if you do, it starts to restrict various things, or if you do, you're going to get admitted to hospital or admitted to care. This is really tricky, and I'm not really, I don't think, coming over that well with it, but I'm just trying to toy with what it's about and why maybe staff are doing what they're doing. And I don't think they're doing it without compassion. I think they're doing it because they've been very much trained, and maybe they are trying to work in the best interest of the person, but maybe the language that we're using or the concepts that we're driven by maybe aren't the best ones. So apologies if that seems to be contradicting what you're saying. It's not meant to be. I'm just trying to put it into some context with, the pleasure and pain of all the years of my involvement with this, going back quite a long time. Thank you.
Yeah, no, I don't think that's irrelevant at all. And it brings back to me the importance of how we use language, how it's absorbed by people who are learning from us. So if you're on the ward, or if you're doing an assessment, if you've got a student with you, they're feeding on what you're saying and how you're saying it, and how that feels to them as well. So yeah, that's something we need to focus on in training, isn't it, as well? Yeah.
I think in my experience, some of the language that's been used with me, with the person that I care for, seems to be like a like, for instance, only a couple of weeks ago, I was told that if something did happen, it would be misadventure, and I did like a double take, and I thought, why did you just say that? You know, and I think they said it to kind of like protect themselves maybe from something. I think it's in need of more different tools to use to make themselves feel that they're safe in what they're doing. Maybe I just think that some of our nurses, some of our people that come into contact with people in crisis need some better tools to use, better language to know how to use in an appropriate way, because it's not very comforting to have that kind of thing said. So
yeah, and I don't think it's comfortable to use them either. You know, go down to that you know, for to be in that position, it's not comfortable. Yeah, so it just needs to have this better.
But that death by misadventure thing, you know, I've heard it in the last month, both in an A&E department from the medical side of stuff, as well as the mental health. So it's obviously a thing that is said, has been heard said, because I don't understand why they would be using that anyway. You know, to me, it's a puzzle.
Now you've put your camera on, I wasn't sure if that's because you wanted to come in on this.
I think really kind of interesting discussions and great presentation. Thank you. I mean, as Keith has kind of hinted at, you know, some of this has been around for quite a while, and partly it's, you know, what we're kind of talking about is kind of cultural. You know, this is something that kind of goes through organisations, and we have to ask ourselves why. You know, people have talked about resources, and we're kind of rationing kind of scarce resources, so we're actually, you know, if you like, screening people out of care, but it's also, you know, you mentioned about training, and I think that's really important, and some of the most kind of effective interventions I've seen in this space have been where, you know, we've got kind of, you know, service users who have articulated some of the issues much better than the likes of me ever can. Getting them involved in kind of training kind of early on can have a real impact on, you know, professionals at early stages in their career. So I think that's part of it. But it's an incredibly difficult thing to tackle, because it is kind of embedded and cultural. But you know, I'm really glad that you've started to do that locally.
Liz and Sue, so I think partly you wanted to come here to see if anyone could help, or anyone was doing more, or maybe further. And I think actually what's happened is people have said, oh, you know, actually this is great, what you're doing is kind of further than anyone else is. And yeah, so what Nikki said, I think they're leading the way, which is, I guess, a bittersweet thing to hear maybe for you. I don't know, but it's
perhaps we could say, if anyone wants to join us, you know, it would if this, instead of just being a local conversation, if this was a national conversation, if this was something that all trusts actually looked at and thought, do you know what, we're fed up of seeing this. It'd be stronger if we done it as a nation. We'll keep doing it local. We'll keep plugging away. But it's kind of, just other people.
Yeah, I think there probably are a few people on the call that would probably feel like they would join you. So maybe that's a good place to finish this section. Really, is that call for people to join you and to
our next public webinar will be on language. Change your language, save a life, Liz. You know, do our first one, do it publicly.
Okay.
Okay, I think that's decided. Okay, and there's probably a few of us that will log on for that. Brilliant. Thank you so much for that really powerful and helpful, and I hope that it sparked things with other people, and I hope that gets taken forward as well, and we've given Chloe Beale lots of publicity as well, and I would say that's a good thing as well.
Thank you.
So we're going to go now to Maggie and Joe, who I've seen